So we're just going to give them a few more minutes. In the meanwhile, I'd like to welcome those who are already here. And this has been a very special journey for all of us involved in these sessions. They're highly interactive, as you will know, as we go along. And we have been blessed to have a faculty of about 20 people from different parts of India and abroad to help lead these sessions with extreme competence and expertise. And so far we've had over almost 700 participants from all over India. We've had over 50 participants from around 11 different countries around the world. And today I'm very pleased to welcome our colleagues from Philippines and Nepal, and our colleagues from India from over 14 states. So it's a very, very diverse group of doctors, nurses, allied health professionals, and all are very welcome. Our biggest crowd today is from Chhattisgarh and Uttarakhand, I'd like to say, has already had over 100 people certified through this course. So very happy to have more people come here. And clearly there is a value that is being recognized, and I'm glad that this is rolling forward so beautifully. To lead today's session, I'm going to introduce you to Dr. Moira Leng and Dr. Jenifer, and two extremely experienced palliative care physicians. Both have been in the field for a long time, and I'm going to let them introduce themselves because I'm afraid I won't be able to do them justice enough. So over to Moira and Jenifer.
Moira, you want to go ahead?
Sure. Delighted to meet you all, those who are joining, those who are already here, and thank you for sharing something about yourself already on the chat. I'm a palliative care physician of 30 years standing, and I've had the privilege of working with India for 20 years, but also in places like Uganda, Gaza, the Middle East. And it's a pleasure to be with you all today and to start off this week of learning together. Thank you.
Thank you, Moira, and it's a pleasure to meet you all in this platform. I'm Jenifer. I am a professor in palliative care. I've been in this field for 15 years, and I worked with Moira, and it's been lovely to facilitate with Moira today. And I'm based in Vellore in Christian Medical College in South India, and it's lovely to meet you all, and we hope we can learn together in this coming week.
So we're going to teach together. One of the sessions Jenifer will lead and one I will lead, but we very much would like interaction, and Jenifer will be starting off. And please keep using the chat as you're using it, and then I will lead the second, but we'll hopefully work together as a double act, but most of all involve you as well. So over to Jenifer.
Yeah, I'm just trying to share screen. Will someone just let me know if you're able to see the presentation?
It's perfect, Jenifer.
Yes, ma'am.
Okay, thank you. So like Moira said, we have we've divided the session into two. I will just take you through the introduction of this course and what you are likely to expect in this following week. And formally, I welcome you all to this training course, which has been largely built on the palliative care in COVID-19 resource toolkit for low and middle income countries, which has been developed by colleagues from India and internationally. And I'm sure many of you would have gone through this, and that would be the base for our learning this week. But we also look forward to learning by sharing experience and what you have to bring and share in this platform. Yeah. So our main objective will be, as suddenly this pandemic has come very unexpectedly, and we find ourselves in forums we haven't been. And the primary focus of this training is to train, support, empower healthcare workers caring for seriously ill patients and families during this COVID-19 pandemic. However, our focus is mainly on patients who are COVID-19 positive and who are unlikely to have good outcomes, either because of their age or comorbidities or pre-existing functioning status, and also to empower you to continue to provide care for those with pre-existing comorbidities which are making impact on their treatment decisions, and address the needs of the wider community, including healthcare workers who continue to try and address the challenges of those affected with COVID-19. You might have gone through these competencies which have been enlisted in your pre-course material. There are 10 of them, and you would see that we have tried to identify how palliative care fits in this severe health-related suffering that this COVID-19 pandemic has brought about. What we would try and focus through this course would be on holistic assessment, effective communication, goal setting and decision making, which will be the latter part of today's session, understanding algorithms for physical symptoms and management of them, understanding essential medicines required for palliative care and the principles in right access to them, recognizing distress, it could be psychosocial, spiritual distress, and offering support in the context of COVID-19, end-of-life care, exploring and understanding the impact of isolation, grief, and loss in this pandemic context, and also to enable compassionate care and avoid burnout for healthcare workers who continue to provide sacrificial care in the context of COVID-19. So the different domains would be triage, symptom control, management of distress, end-of-life care, and support for healthcare workers. The way this is done is in a flipped classroom method. Can I please request the participants to mute their mics? Thank you. So you would have seen this ebook, which is the palliative care resource toolkit in COVID-19. There are 9 webinars, so it will be of great use if you can listen through those webinars and come with that knowledge and your experience to come to these sessions, which would be facilitated by experienced healthcare professionals who've had experience in palliative care across different settings, and that would make the learning much more interactive and meaningful. So I encourage, even through this session, if you can put in your thoughts, your comments, your questions in the chat box, and we would take them along the way. So this ECHO teaching sessions are also to signpost you to relevant national and international resources. Like I mentioned, we want it to be an interactive session. This is delivered in English, but we have these trainings happening in Hindi as well. So one other resource which I would like to highlight here is an app, a mobile app called the PalliCare app, spelled as PalliCare, which was developed by colleagues at Bangalore from the Karnashraya Hospice. It's a very, very useful app where you can go in for quick guidelines on symptom management, communication, and palliative care approach in different settings. The ebook will also give you very good algorithms for symptom management, and these resources you can use in your training, and you can cascade or you can continue the spread of this, the wealth of information in this ebook. And if any of you are interested in translation or adoption or adaptation of it for your local settings, please contact one of us. I'm just going to take you through the definition of palliative care. This is a new consensus definition that has come sometime in May 2020. So the key words have been highlighted in green. So palliative care, many of them may understand it as just end of life care, terminal care. Okay, if you ask someone, maybe a few years ago, they would say, okay, do you prescribe morphine? Palliative care is all about morphine. But what I want to emphasize is it is an active holistic care. It is not just a laid back care where you're just waiting and keeping the patient comfortable and waiting for him or her to pass on. It's an active holistic care of individuals across all ages with serious health related suffering. And this pandemic has really put palliative care's strength into perspective. Anyone with serious health related suffering due to any disease, due to any severe illness, should be offered palliative care, especially those who are near the end of life. The primary aim is to improve the quality of life of not just patients, their families, and their caregivers. So if you look at this picture, you will see that palliative care starts quite early on in the disease trajectory. It doesn't wait till the patient nears the end of life, but starts on the role of palliative care starts quite early on, and maybe the amount of input or the amount of palliative care increases as the disease trajectory moves along the line, and it continues on as bereavement care. So though palliative care has come into focus during this pandemic, it is not something new. It has found its place in other humanitarian settings, like in natural disasters, floods, and in refugee settings, like the Nepal earthquake, the Kerala, Assam floods, and South Sudan refugee camps. And there are different international bodies which have recommendations and which have put forth documents on palliative care in humanitarian crisis, like the PalChase. And this has gone into, palliative care has been incorporated into the health system response in the WHO documentations. And that is a welcome move. This particular Lancet article really calls COVID-19 as a tsunami of suffering. And I'm sure each one of us will here would agree to this right use of terminology, that it has really brought a tsunami of suffering, which has not limited itself just to the health of people, but has gone and affected different domains. And what they have listed as the focus of palliative care has been communication, goals of care, symptom control, especially those who are not receiving ventilator support, psychosocial spiritual care, end of life care, and support of staff or healthcare workers. And you would see these themes being mirrored in the palliative care and COVID-19 resource toolkit. This has really been a welcome focus. The 73rd World Health Assembly has incorporated in their COVID-19 response, has incorporated palliative care into it. Committing governments to deliver palliative care services alongside safe testing treatment for COVID-19. I think they identified the need and the strength which palliative care can provide in this pandemic. The governments must pay particular attention to the protection of those with pre-existing health conditions, older people, and people at risk, in particular healthcare professionals, health workers, and other relevant frontline workers. So this picture tells us different things. Tsunami of suffering and the role of palliative care among children, prisoners, the elderly, the migrant workers who are trying to get back to their countries, and in refugee settings also beautifully trying to maintain social distancing. So this is the situation now, and these are all vulnerable groups of people. We need to be sensitive to their needs, which will come up. The pandemic has not just resulted in suffering, which means we would be really tied down and bogged down, and but there is a brighter side to it. The pandemic has also helped people to express solidarity, express compassion, express care in different ways, expression of love, expression of catering to the basic needs of people through providing food and other basic supplies. And this says we are all in this together. It has just brought the whole globe together as one. And that, I think, is the strength, even as we try to provide care in this difficult period. So it somehow goes without saying that all doctors are palliative care doctors now. Doctors from different specialties have volunteered, have come forward to the need of taking care of patients with COVID-19, have started providing care for those with comorbidities who come with intercurrent illness. So every health worker is struggling in some way or the other to offer solace, preserve dignity, minister to the distress of patients. And I'm sure that is what has brought each of you to take this course, so that you feel empowered and you feel supported. And we are trying to share patients' existential suffering about what the disease might have in store for them and our shared communities. But what we are also trying to do is align our care, not just with what we know, not just with what our experience has taught us, but keeping patients' perspectives, their families' perspectives in mind, patients' values, they are prioritizing, and synthesize this with our prognostic judgment so that we give candid and heartfelt clinical recommendations and don't just assume all protocols and algorithms, everything works one and same for everyone. And yet, this is not a luxury. We bear witness and to this ceasing suffering has always been in the heart of medicine, without which our endless calculations and research become simply the clever arraying of numbers, the deft processing of flesh. There's so much more to be done, so much more of our patients' life symptoms and experiences to be attended to and apprehended. It's not just about treatment. We also need to make sure that our patients feel seen, feel not abandoned, feel cared for, feel supported during this difficult time. So I end with this slide, which is taken from a Lancet letter written by Moira and some of her colleagues. It talks about suffering and illness and dying, how it reminds us of the universal truth of mortality and humanity. We can really allude to this phrase, isn't it? The pandemic has brought mortality into focus, but also has kindled humanity. Palliative care is rooted in the recognition of our common suffering in illness and dying, and our compassionate response to suffering and our shared humanity. Fundamentally, palliative care seeks to ease suffering and uphold dignity. So with this as a prelude, I would like to hand over to Moira to continue on with the second part of the session. But I really would like you all to put in comments, suggestions, and we will go further.
Thank you, Dr. Jenifer. And actually, thank you for that lovely introduction. We've had some comments. People are keen to learn about communication. Several people are keen to learn about ethical decision making, and some to have frameworks to help them interact with their hospital systems. So that's Very interesting. We're looking forward to your input. And others are saying they're new to palliative care, so they're wanting just to see how the palliative care approach handles all the way from triage to bereavement. And I think we have one interesting comment from our colleague from Lourdes Juarez from Goa, who's particularly asking about the post-COVID continuity of care. And this may not be an issue we specifically cover, but we'll try and make sure we do talk about that. We've actually been rewriting our ebook recently, updating it, and this issue has come up as something that we need to be paying attention to. So I want to thank everybody for their interactions on the chat, and Dr. Jenifer now will be taking over, interacting with you while I lead the second part of the session. So thank you so much.
Thank you, Moira.
Okay, so we move to an area where many of you have said you are particularly interested. I'm just going to, yeah, and that is triage. Now, this can be a very challenging area. It can also be an area where people feel very torn because they have on the one side the family members asking for help, on the other side a very overwhelmed health system, or maybe actually a health system that is not working as it should do. And how do you balance that? We're going to touch mostly on the decision-making process, and some of you have asked about that. We're going to introduce particularly a triage algorithm. If you haven't downloaded, as Dr. Jenifer said, please do download this. Please look at it in your sessions. We'd love you to think of how all these algorithms might work out in your settings, and then tell us whether this is working or not for you. Dr. Jenifer's also mentioned the PalliCare app, and that's particularly useful for adult symptom control, and we won't cover every bit of that in these sessions. We're going to go back to our ethical principles, but really just to touch on them and to talk about how our ethical principles help us find our way through this decision-making challenge. And as my starter question, I'm going to ask you to just remind us, because in the webinar we go into in more detail, but to remind us, can you remember what the 4 basic ethical pillars are? If you remember, put them in chat while we're chatting here. Now in the webinar, if you want to know more, all of our webinars contain more of the theoretical knowledge, but these sessions are designed to be interactive and to have slightly less of the theory and more of the theory into practice. Of course, ethics bring our own values to the fore. How do we make decisions? On which basis do we make decisions? Do we make them based on even an unconscious discrimination or bias? And that's something it's good to challenge in ourselves. And Dr. Jenifer has already told us some of the particularly vulnerable populations, and those are populations which also can be subject to bias. Now, Dr. Jenifer, I'm wondering if anyone has told us the ethical principles yet.
Yes, Moira, they've listed the 4 pillars of medical ethics: autonomy, beneficence, non-maleficence, and justice, which is great.
Wonderful. Thank you for that. Sorry, yeah. So we'll work through how we apply these in our setting. Now remember, ethical principles are not legal, not legally binding. Ideally in your setting, you will have good laws. Now, India's laws around end-of-life care were not so clear, but they have been clarified in the high courts, but that may not have moved down to state level. Philippines, I don't know, please tell us, do you have good ethical legal frameworks for end-of-life care and palliative care? Be good to know. It is also important that we recognize that we practice in particular cultures, and it's not one culture for one country or one state. Often within institutions, there are different cultures within family groups. So our ethical issues should not be culturally dependent, but we work them out in the context and culture we find ourselves. And it's helpful to think of that in advance so that we don't find ourselves doing what I call situational ethics. That means when we are thrown into an unexpected situation and we start making decisions just based on what's in front of us without understanding the ethical frameworks to that. Because this is a balance. It's a balance of the benefits of any intervention, the burdens of any intervention, the legal frameworks, the wishes and best interests, that's autonomy and beneficence. the need not to do harm, that's maleficence, and the wider society issues which kind of are picked up in the issues of justice. We want to find a balance, and sometimes that balance can feel difficult, and sometimes it can feel hard to find our way through that. Dr. Jenifer, any comments in our chat that we should know of?
Oh, not yet, nothing, Moira. Okay, just as you're asking, there are some coming in. So you had asked about the legal framework, any existing legal framework in Philippines. So I think our friends from Philippines are saying mostly in the area of ethical information sharing and communication.
Okay.
Some institutions have bioethics committees which can be considered for different or difficult ethical issues. Yeah, right.
Wonderful.
Yeah, I think that's
Wonderful.
very helpful, and often, yes.
That's really helpful. And when we come to how we make decisions, and particularly in the context of COVID-19, knowing your institutional ethical framework and actually calling on them in difficult situations is really important. So here is our maze. Here's our maze, which is ethical decision-making and triage in COVID-19. What we want to do is see if we can find a pathway through this so we don't get lost, we don't get frightened, but we find ways in which to practice compassionate care with an ethical framework. And I think we've talked about some of these issues already. We have vulnerable patients. There is quite a bit of desperation. I've seen many pictures of people and stories trying to get help. And actually, I have my own story this week of a young man I was trying to get help for, who unfortunately didn't get the help that he needed or deserved. And he did die of COVID-19. And just the feelings that creates, that feelings of helplessness in me as a clinician, as well as in family members, and how difficult that is. We don't have equal accesses to resources at the best of times, never mind in a pandemic. And I think this is crucial for this week. Often we just focus on the medical decision-making and not on the holistic support that surrounds that. So thank you for joining this week, because that's what we want to think about. How do we do good medicine, but with an appropriate holistic focus? And of course, there's issues such as stigma, which we'll talk about later, fear for ourselves as healthcare workers, as well as all those we're caring for. There's this language issue. I talked about unconscious bias. I think sometimes our language can drive that. We use words like suspects, don't we? And these are really unfortunate terms. We need to try and challenge ourselves not to use these terms. And Dr. Jenifer mentioned how this pandemic was largely unexpected. Although predicted, it was largely unexpected, and we're all under pressure. So I want to introduce you to a narrative. It's a family that we'll work with for the next week, for the next 5 days, and the different issues we'll discuss in the context of this narrative. And I'd like you to engage with this story and as we go through the week. So it's a gentleman of 55. His name is Mr. Ramesh. He has a number of comorbidities, which are often linked. Diabetes, ischemic heart disease, obesity. Of course, we are finding that obesity is on its own a very significant comorbidity in COVID-19, even in younger patients. He unfortunately had a stroke 6 months ago and has been left with a dense hemiplegia and very frequent chest infections. He's been housebound for some time, even before COVID-19 pandemic arrived, and he's needing help with most daily tasks. His wife and his sons are caring for him. So can we start to think and put on chats, what are the issues in this scenario? This gentleman at the moment doesn't have any positive diagnosis of COVID-19, but what we want to illustrate in our triage and our thinking is that many of the issues come up before the moment of diagnosis of COVID-19. So as you read through this scenario, what are the key issues that are coming up in relation to the gentleman himself and his family and social context that we are going to need to take care of or pay attention to in the context of COVID-19, and will be relevant if we look forward to a time where perhaps there are specific triage decisions to be made. And I can see there are people writing things, so I'll hand to Dr. Jenifer just to comment what is being said.
Yeah, I think they're really picking on the right issues. Is age, is comorbidity, which is not just single, multiple comorbidities, the knowledge of the primary caregiver, the burden in providing care for him, elderly, diabetic, largely immunocompromised, unhealthy lifestyle, the current infection and the burden on the family. Yeah, so.
Thank you so much. That's great, and thank you. So I can see already you're assessing the situation well. You're assessing it holistically. So thank you for doing that. You're noticing the significant levels of comorbidities and also the age of this gentleman, and you're also talking about some of the issues in terms of the primary care interventions or support, and also the social support. And just think more about how we might be supporting, because one of the issues is we are saying people with comorbidities may not be appropriate for certain interventions. We're coming to that. But the other side of it is, what do we do with our patients in the community living with comorbidities? Do we simply leave them waiting, terrified, scared for that COVID-19 diagnosis? Or what are the sorts of things we might be able to do to support this family and in the particular challenges of COVID-19. Jenifer, is anything else you want to share from the chat?
No, Moira, I've just put it all together.
Lovely.
I think one other factor that has been added on is the emotional turmoil that can come on the family members. The other thing is he's housebound, he can't do his daily task, which somebody else also had mentioned earlier as the burden of care that Mr. Ramesh might need.
Okay, thank you so much. So let's just look at the clinical scenario and the research, because it is important to base our decision making on good research. There are now a number of studies. I'm quoting this one from the UK, but every week I'm seeing, in fact, people are saying the volume of research in COVID-19 is also completely unprecedented. I would also remind you that even this course has been published and some of the initial findings from training. But we're seeing here, this is a graph looking at the age of a patient, and pink color are those who were admitted with COVID-19. So in this context, the UK, that means they had moderate or severe symptoms, not asymptomatic. And these are the ones who were discharged in pink. In yellow, at the time of the study, they were still admitted for ongoing care. And here we have the purple color. These are the ones who died. And these would have all had almost certainly severe COVID-19 infection. So we begin to look at that. And some things are jumping out at us, aren't they? The significant increase in mortality with age is here. And also the fact that young people in general have a much better outcome. Very few young people were dying in this study. So looking at that, one of the questions that came up early in this pandemic is, should we just have a cutoff? Should we say over the age of 65, for example? That was suggested in one setting. We should not give interventions that would include admission to ICU. And again, I just put that question to you. If we are saying that those who don't recover well are those who are elderly with comorbidities, should we have a cutoff? And does that mean we are writing off our elderly patients? So just some thoughts on that. Are we writing off our elderly patients in this COVID-19 pandemic if we say we're not going to treat you with ICU admission? Is that ethically okay? Is there another way in which we can make that decision? But of course, the other side of that is, if the elderly are not going to benefit, should we be starting an intervention that doesn't benefit? That is that non-maleficence. We shouldn't start something that is not going to be of benefit. So we're getting into the nitty-gritty of the tricky ethical issues here. Jenifer, has anyone mentioned anything to date?
Not yet.
That's no problem.
It's an uncomfortable question, but we'd really like you to freely put your thoughts. We are all looking at it together.
And so I think what we've learned, even in the medical fraternity, is a bit more about how we manage that. I just draw your attention to an excellent briefing note. There were briefing notes on COVID-19 produced by the Global Palliative Care Organizations you see mentioned here. You find them in the WHPC, any of these organizations' websites, you'll find them. And this was the one on bioethics. And what I loved was it added to our principles that we've already mentioned, some other ethical ways of thinking, non-abandonment. Whatever we do in triage, we must make sure we don't give the impression we are writing people off, that we're abandoning anyone. That does not mean everyone should have the same treatment protocol. We must tailor our treatment protocols, our interventions, to the situation we find and to the evidence, the best evidence we have, and to the resources that we have. We must do that, but we should never, never let anyone see they're abandoned, particularly in COVID-19, because people are already isolated. The whole business of infection control means that people feel isolated. So we must do all we can to ensure good communication, to ensure family members feel that we are with them, trying to find the best care for their family member, that we're listening to the wishes of the patient and the family, and that we are keen to look at the whole of that person's needs, the spiritual, which we will come on to later in the week and we might touch on today. Spiritual meaning, how do you find meaning and purpose? How do you find hope in a situation like this? While respecting confidentiality, which you mentioned already, while respecting the individual needs of that person. So the summary is, we make a decision for that individual and their families based on our ethical principles, these also principles of non-abandonment and whole person care, and we make them based on the best use of resources and the best evidence for what will benefit that patient. We should have a plan and strategy in place. I pay tribute again to the state of Kerala, where this training began. And one of the reasons why it began here and is extended is because Kerala had developed quite good systems of care for previous emergencies, such as the Kerala floods, the Nipah virus. And they have a clear system of how first, second line treatments will be managed and how feedback will be given. And it's very much based on empowering the community, empowering the healthcare staff, and having a clear line of referral. I'm not saying it works perfectly, but it's a good system. Try and make sure you know your system. If you don't know it and you want some help in trying to find it, PalliCovid India may be able to help you, put you in touch with people in your setting. Jenifer, I can see there's some people putting things on chat. What do we have on chat? Yep.
Yeah, we've had some good comments come in that the elderly can't be just written off because of age. And there are reports of people who are even more than 90 who come through this disease. So it calls for decision making. It calls for decision making on an individual basis, case by case. Age alone is not a factor. Other factors should be considered. No one should be left behind. I like that, because we don't want anyone who is elderly or who falls beyond a certain age group to feel that they will not be cared for, they will not be considered for optimal care. So thank you. Very good comments that have come in.
Thank you. Yeah, thank you. And that phrase, leave no one behind, is an interesting one. It's even included in the declarations from the WHO about universal health care. So thank you for bringing that up. People have a right to health care, and many of us, I think on this call, are working to make sure that that right is respected, that people have a right to reasonable health care in their setting. And we know that health is something that tips so many families into poverty or pushes them further into poverty because they don't have universal health care. And when I talk about COVID-19, I say that the world is as safe as its poorest health system, its weakest health system. And countries that maybe felt a little bit complacent are really being challenged. And there is a global solidarity that Dr. Jenifer already mentioned. So let's come down to thinking how we might work our way through. This is a goals of care algorithm. We're actually updating this one. It's a little hard to read, but you can find it. Age alone is not an issue, but age is one of the issues. Do you follow? So age is one of the factors we take into account, but I totally agree. We have chronological age and we have functional age. And the comorbidities give us a clue to the functional age. And it's not that anyone is going to be withheld treatment that could benefit, ideally. I've already shared a situation very close to me where that did happen. But we don't want that to happen, but we do want to make appropriate decision. So this is the beginning of a goals of care discussion. Looking at the situation and thinking, okay, is this a very straightforward setting where we go straight down our COVID treatment paths? While we're doing that, we're giving holistic care. Or is this a situation where we do have frailty, we do have comorbidities, We are seeing a lack of response despite oxygen, because we know that high flow oxygen is a very important first line now treatment for COVID-19 along with other interventions. And in those circumstances, we're starting these conversations. We're checking understanding. We're trying to find out what people are expecting and what they want of the interaction they're having with healthcare. This should be part of any healthcare interaction, so that when we do have to make decisions that are difficult, the family already feel listened to, the patient feels listened to, we understand something of the context, we understand how much the patient would like to know themselves. Of course, in COVID-19, we may be struggling if the patient is not able to speak, or if we're the PPI, we'll talk about communication, particularly in the day after tomorrow. But it's good to try and find out all we can, and in particular to form that important relationship, even if we do it quite quickly, that says, I'm interested in you as a person, in your family, and in what you understand and what you would want from us. And that's going to make the next stage of discussions really important. So let's move on to that next stage. So here we have the algorithm that we're using in this training for COVID-19 triage. And I'd like you to look at this. We've designed the algorithm to take you through on a green, yellow, or red track. And the green track is straightforward. This person has no significant reason for any additional levels of triage, but they have moderate or severe symptoms, and they should be immediately put into a good COVID management treatment system. And that should include holistic care, particularly, of course, in these times of isolation where communication with the family is vital. Some settings have set up specific communication teams, and it would be good to know in your setting what is happening. But this week, we're looking particularly at those with chronic disease. So we're looking at people who have comorbidities, who have pre-existing poor performance status. Now, there's a number of ways to measure performance status. Those of you who are familiar with the WHO performance status, which is a 0 to 4 scale, I wonder if you could tell me where Mr. Ramesh would come on that scale. And also think about how many comorbidities did he have? What is his performance status? And his mental status can be also very important here. Although please bear in mind that the delirium that comes with the illness should not be taken as a sign of long-standing mental health, brain failure. We must be very careful. It's his pre-morbid, it's his pre-COVID status that we're trying to find out about. Now, some people have asked us, even on these calls, what about those with disability? And that's a very, very important question, because of course, these are factors we take together. There may be someone who is, for example, paraplegic, or even quadriplegic, or who has significant problems like cerebral palsy, or has another form of disability, but whose functional status is excellent, who has been managing well, might even be self-caring or getting help. Don't write off people because they're disabled. Don't write off people because they are elderly, but also I've just used a pejorative term. I've just used a term write-off, where actually I don't want us to say that. I want us to say, give the right treatment for the right setting, give the right intervention for the right setting. So I want to ask you now a tricky question. We've talked about Ramesh. We've talked about the ethical principles. We've talked about some of the things that help us make decisions. Do you think that Ramesh, with his functional status, and I'm going to ask in a moment if any of you have said what you think that is, with his comorbid status, with his premorbid functioning, do you think that we should be triaging this gentleman to go to an ICU setting to be considered for invasive ventilatory support? We're going to give him oxygen. We're going to give him all those other interventions if he needs them. But I just want you to commit yourself. And again, this is an open sharing. Do you think he's likely to benefit from ICU admission, or he is not likely to benefit? So say if he's likely to benefit, just write likely. If he's not likely, put unlikely. We're trying to decide whether he's going to move onto this yellow track or onto this red track. And I'll hand back to Jenifer just to see what is coming on the chat.
Okay, there seemed to be quite a universal response. Most of the whoever has responded has said dread and unlikely. Yeah, everyone's seemed to be very clear that it's unlikely.
So do you know, so in a sense, what you've all done together, we've done together, is we have triaged this gentleman in terms of his clinical decision making. And we've triaged him not based on any discrimination. We've triaged him based on our understanding of the setting. That doesn't mean our work is over. Our work has only begun, yeah? Because we now need to communicate that effectively. We need to have a way in which, if there is a difference of opinion, that we support the family, because often what you need is give support. If we get into a fight where it's about, we decide this, you want this, it's very distressing, and we also risk the patient being moved to another setting or being the family left with this. So this is where our important communication is these black boxes are there because they are essential. They're essential. Effective communication with the family, feeling we're making a decision based on the best interests of the patients, not because we have somehow neglected them.
Oh.
And yeah, Jenifer, yeah.
Now go ahead.
Yeah, and also during that whole time we are giving effective psychosocial and spiritual support, including for the patient, Now, I also want to point out that sometimes the situation can change, the evidence can change, the treatments can change, the patient themselves conditions can change. Sometimes we've gone down this yellow line, but it's very clear that in ICU and critical care, people are not improving, and then we move back to a red line. Despite invasive support. And of course, we very much hope that people will be able to move back to the green setting when they are improving and no longer needing intensive care support. But let's come down here. So you have made a decision, and thank you for making a wise decision to say this person is unlikely to benefit from invasive ventilatory support. And actually, we're seeing very poor survival rates if we do ventilate patients with this kind of comorbidities. So we have to communicate. This is when documentation is really, really important. Make sure you have a documentation process in place, and make sure that you use any institutional ethical systems that are there, and consider if there is a challenge or if the situation is particularly hard, bringing in other colleagues. Some places have people readily available in the triage setting that are, if you like, the external review. They call them the three wise men, people you can call in to say, the clinical team have made a decision, the family are not so happy, can we just have your external review? Some of you will have ethics committees for that. I would just say that the communication is the crucial part of this. If we can communicate effectively, then usually we can take the family with us. We can acknowledge how difficult it is. We can acknowledge how painful it is, but we can say we want the best for your family member, and we don't feel the best thing for them would be a futile intervention that would potentially cause harm, both in terms of the suffering of the patient and also the finances and resources. But instead we want to do something that is going to cause the most support. Now, then we have to do that. We have to offer holistic support. We have to offer good symptom control. And we have to offer good end-of-life care if that is what is the end result of the scenario. And after that, we have to offer good bereavement care. And during the rest of the week, we'll be looking at those components: symptom control, communication, end-of-life care, managing distress. Any particular questions on this triage algorithm or comments that are coming up in the chat just now, Jenifer?
No, Moira, I've only re-emphasized the point on good communication and documentation being the key for good ethical decision making, because often we may have made the right decision, like we know it is not likely to, Ramesh might not benefit out of escalating care up to ICU, and that might be the right decision. But if we have failed in our good communication, sensitive communication, or in our documentations, it can cause distress in the with the family members. Okay, we have a question or rather a comment. It is beneficial to introduce advanced care planning too if patient is unlikely to benefit. Absolutely. Araf, Ofina are you from Philippines?
So thank you. I think Philippines, I think I saw your name earlier. Wonderful. You know, advanced care planning is a very interesting concept. I called it goals of care in the last slide, but Jenifer is entirely right. Some way, and that's why we introduced Ramesh before he got sick. The whole point was sick with COVID. He was already unwell, because a lot of these discussions and decisions we may be able to make well in advance. So advanced care planning, goals of care discussions, pre-hospital, at home, goals of care discussions. If you're working with chronic patients with chronic illness now, start having these conversations so that they are aware that we need to establish our goals of care and establish them early, so we're not making them in a very emergency situation, which can be very painful. So thank you for bringing that up. I'd be interested to know how many of you are working with advanced care planning processes. You know, where are you managing that, Dr. Fina, in your setting? Because I think in many settings, particularly on the front line, in primary care settings, advanced care planning in India is not so common. I would be very interested to hear how that is in the Philippines. And as you're answering that, I'll go on to the next slide, then I'll come back. So please do share your experiences with goals of care discussions and advanced care planning. Let me just cover the next slide and then we'll see your comments. So this is just summarizing what we had there. The importance of communication documentation, as Dr. Jenifer has also emphasized. The importance of remembering futility. Futility is when an intervention is not likely to cause benefit and very likely to cause harm. And in that situation, futility is also an important part of our ethical thinking. Of course, we're remembering our importance of managing the patient holistically, including their symptoms and end-of-life care, as we have said. WHO performance scale, this gentleman is actually at 3 or 4. So he is largely in bed and needing care, or sitting from bed into a chair, but is needing a lot of care. We put WHO scale here because it's a simple one. There are some more complicated scales. If you have one in your setting, again, share with us or continue to use it, but you need to have some kind of objective measurement. So we're suggesting comorbidities number, pre-morbid mental state, and WHO performance scale. I will mention a couple of other scales. Our colleagues in ICU often use an organ failure score. That is more for predicting outcomes. Is it a single organ failure like respiratory alone? Or with COVID-19, we know there can be renal complications. There can even be neurological complications. Is there more than one organ involved? The clinical frailty score came from Canada, is widely used in the UK and other settings. It perhaps has more resonance for the elderly, but I want you to see number 9. It does specifically mention anyone who has a terminal illness. And in the context of the UK, that would mean a prognosis of less than 6 months to a year. And on this scale, our patient would actually be at 7, So he would be high scoring on the clinical frailty score. He would be high scoring on the WHO performance scale. And I would therefore agree with you that our triage would be quite clear. This gentleman should be triaged not for referral to ICU, but for active holistic care. Dr. Jenifer, anything coming up in chat you want to share?
Yeah, nothing new except Dr. Pallavi has re-emphasized the need for initiating communication quite early on rather than late. Ara has come back saying it's not always practiced in all settings. This is pertaining to advanced care planning.
Yes.
But we still try to introduce early so we can also consider their preferences, the patient preferences. Yeah. Rodora, in her community, it is difficult to begin discussions on advanced care. Very true, I agree.
And that's a really good point. And you might be able to start thinking and start sharing, why is it difficult? So what is it that makes it difficult? Because we're all agreeing these conversations are important. We're agreeing that these conversations help us to make good decisions and help patients and families to feel that they're being listened to, but we find it difficult. So maybe you can begin to think why you find it difficult as we come back to looking at Ramesh. So this is what we knew already. And now we know his WHO performance scale and his clinical frailty scale. And so you've covered a lot of this already because you covered this so well, but we know he has high risk, particularly if he has severe respiratory complications. Let me tell you a bit more about him, because we're going to learn more this week. He's a retired mechanic. He has not had a lot of extra resources, but his son has managed to start working in a provision store, and his other son was working in the UAE, which is a very real issue for people in India, and I think also in the Philippines, that many of our younger relatives work in the Gulf countries. But Manesh and his wife has had to come home on quarantine, and they're living in 2 small rooms in a semi-urban area. Ramesh was active before the stroke, but as we know, he has really been very housebound. Neighbors are calling and saying he's at risk, and he's becoming anxious, and he's thinking he's going to be neglected in his care. Here's some more issues coming up. So I don't know whether you've been sharing on the chat why we find it difficult to have these conversations. If you have, I'll ask Dr. Jenifer in a moment just to summarize what you're saying. But have a think and see, are there any more issues coming up in this scenario that we want to take on board when we're going to be addressing this gentleman's needs? Have a think more about some of these issues I'm bringing up in this conversation, particularly about his social and his psychological concerns, some of which are coming up here, and maybe some of the societal concerns that are coming up. Dr. Jenifer, anything that people have shared?
Yes, a bit more about this advanced care planning. I think this is from Nepal. I might be getting your name pronunciation wrong. Dr. May from Nepal says they have an advanced directives policy, but in real life, it's a big challenge to actually introduce it when faced by the care team. And this has been also reiterated by others, saying there are many barriers at the doctor-patient's front, which makes it very uncomfortable to start talking about advanced care plans. We have one other comment saying futility concept has been debatable from perspective of family. Medically may be futile, but a family may believe in doing everything as there is no certainty.
So thank you. You brought really important issues up there. And one of the challenges we have is we can make these decisions clinically. How do we communicate them effectively? Because, you know, we, of course, as family members, you want everything done. But I think if we develop the skill of actually exploring the implications of various interventions, but most of all, and this is the bit I come back to, it's like playing tennis. If you are standing on each side of the net and you're batting back, you're saying, no, 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 doctors, we know better, nurses, we know better. The other side, they are batting back saying, no, 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 we're family, we know better. You are going to struggle. But if you come round to the same side together and say, we have something to do, we're going to do this together. You have your skills as doctors, as nurses, as healthcare workers. The family have their understanding of their culture and setting and their wishes. And together we're going to make the best. That's a really crucial thing. Can we work as partners with the family, as opposed to getting into a situation where it's the medical knowledge versus the non-medical knowledge? And that's the crucial part of communication and breaking bad news. But I am also intrigued because I'm hearing comments from Nepal and other places where you're saying we have these, but there are barriers. I wonder if you could tell me what those barriers are. One of the barriers I think you're telling me is that families have different wishes. Any other barriers that you're finding to having these effective advanced care planning discussions, as well as goals of care and triage discussions? Jenifer, I can see there are more people adding things.
Yeah, you can please put in your thoughts about what the barriers are and what you practically face. But we've had some responses on the further challenges pertaining to Ramesh with this extra information. The stigma and discrimination from neighbors, emotional, mental distress. Someone else has brought about this important question about what about elders who are living alone? How can we care for them?
Great. So really important issues. And, you know, I was even hearing of people who can't even pay for an ambulance because the ambulance prices have all gone up. And I think there's an issue here also of societal stigma, is there not? You know, we've heard stories of doctors that are not even allowed to go back to their own places of living because their landlords have asked them to leave. And I think, there's a lot of fear and stigma that we need to be aware of when we're looking at this illness. But thank you for picking up some. There might also be, how is Manesh going to feel if he comes back from UAE, somehow his father gets sick and he thinks, I brought this disease back? Yeah. And how are they going to manage all that physical distancing in this small home? So there's some really practical issues here, and thank you for mentioning them. And I'm looking forward to hearing more about the barriers as we go on. Effective communication, this we will talk about all of this week. But I want to mention, particularly in triage, that this importance of being present. What I mean by that is the most powerful therapeutic tool you have is yourself. And the way in which you listen, the way in which you use your non-verbal, particularly in this setting, are verbal as well as non-verbal. So the way you position, this picture here is looking at an ICU setting and someone at least laying a hand, all in PPE, done safely. The ways in which we try and preserve dignity and show empathy and compassion. These are the crucial things. They may sound very abstract, but these are the crucial things that are actually going to make a difference when we come to have these conversations. And the being present is saying, right in this moment, you are the most important patient and family that I am dealing with. This may only be for a short time. We may have others. I'm not pretending you're not busy, but practice this ability to just show that for now I am listening to you and I'm hearing what you're saying and I'm not abandoning you. This quote, unfortunately, was from a young man who died very scared in an ICU in Zimbabwe. And I was telling my own personal experience this last week of a young friend who was also very scared in ICU, and those are difficult. Let's find a way to be effective in the way we practice our communication. Anything coming up, Jenifer?
Yeah, so in terms of what makes us uncomfortable to initiate conversations around advanced care plans is that we are uncomfortable. Doctors, there is a lack of training in how to go about having these conversations. And Dr. May has mentioned that there's a superstition, like if you start talking about this, this might happen. And the taboo about talking about death. Very pertinent points.
Yeah. And I'm glad you brought that up. And I work in Uganda and other African countries a lot, and that's a very strong idea. If you actually start having a conversation that might mean you're talking about planning for end-of-life care, then in some way you have cursed the situation and you are going to, your words have power. So I think this is very important. That's the cultural context we mentioned. We still need to be able to do this, but we may need to make sure we're doing it in a culturally sensitive way. And we're, particularly if you're like myself from outside a culture, you're very much doing that with colleagues who are understanding of that culture, and you're listening more than you speak. So this is, please keep adding, we're coming just to the last 10 minutes or so, but we've talked about preserving that continuum of care. We've talked about the ethical frameworks that are needed. We've talked about effective communication, and this will definitely come up again because it's so important. We've talked about how we escalate and de-escalate treatment using algorithms and communicating and documenting those and needing supervision. And we've talked about the importance of holistic support for patients and families before they come in to a hospital setting or a COVID setting while they're at home, particularly those who are living with comorbidities. And we've, I think, challenged yourself to think about areas, even when you, without meaning to, are having unconscious bias or discrimination, and the importance of valuing that person in that moment that you have an interaction with them. I'm going to just finish a few slides and then we'll come back for last comments and questions. So let me just finish off this talk. I was really intrigued to read this early in the pandemic, a conversation between an Italian critical care colleague and New York, both facing initially Italy and then New York, a huge pandemic surge, both struggling, both feeling overwhelmed. And the Italian doctor says, I have to forget this is a human in front of me. And the New York doctor says, yes, I'm used to doing everything for them. I'm used to being almost like pushing them back, pulling them back from the brink of mortality, and now I can't. And look at this phrase, I have never felt less useful. But look where they come back to. They say, but the one thing I can do is value this patient and family. I can be a person in that situation. I can stay human. It may be painful, but it's the only way we can actually offer compassionate, dignified care. I have been challenged by my privilege of working and teaching in Gaza. And a young medical student, we were teaching palliative care in the third year, teaching palliative care in the way that Dr. Jenifer has talked about a holistic approach to everyone with a life-limiting or life-threatening illness who has severe health-related suffering. And I asked him, what do you think we're talking about? How is this going to impact your practice? And this young man said, humanity until infinity. Now, isn't that amazing? That's from a young man in a situation where there is a lot of inhumanity. Many of you know the situation in Gaza is very painful for the people living in Gaza and very, very unjust. Isn't that a wonderful phrase to come from someone in that situation? What does that mean for us to live and to care for people with humanity until infinity? And to care for people even at those important moments. This was a very well-known film star from India, a very wise person, who talks about that painful conversation of letting go, but how important it is to have those conversations. Yes, we're physically distanced and isolated, but we must be together in the way in which we interact socially, and I think more than ever globally. Thank you for joining this conversation, because you're part of that global solidarity as we meet together from across India and outside India, be able to take this forward. There are many references you will get in your papers, but I'm going to stop sharing now. And in the last few minutes, let Jenifer just summarize what we have here for in the last few minutes from the chat, and any comments, Jenifer, you would like to make as well.
Yeah, so thank you all for this interactive session. I want to read one of the quotes that Dr. May has mentioned by Dr. Ira Bayok. I have a healthcare directive not because I have a serious illness, but because I have a family. I think that perspective is beautiful to see, that it's not because I'm dying and you're after me because I'm dying or because I've been affected about the illness, but what it is doing to my family and people around me. So thank you for sharing that. And yeah, I sense that you've all also identified with a lot of barriers that come with this, this inability to initiate some conversations. And I'm sure the communication session on day 3 will be very helpful. Sometimes we need to hear certain things we are doing again to feel all right about doing the same thing, or maybe tweak it a bit, or even to refresh our own selves to continue to do it. She's also put in another reference, Medicine and Compassion by, sorry, it's more up. Medicine and Compassion by C.N. Rinpoche, yeah, and Dr. D. It's a wonderful reference on humanity until infinity. Yeah, thank you for sharing those quotes and references, Dr. May. I'm sure everyone's found that useful.
Lovely. So
yeah,
thank you for carry on, Jenifer.
Yeah, I was just about to say thank you for joining, and we've all learned together from what you've shared. And so it's not like the decision making is a very dynamic process. Algorithm is not a set, it's not something set on stone, but it always gives us a place to fall back, you know. So to keep that as a framework, but go case by case, start early in your decision making, connect with the patient and the family. And it's a dynamic thing. So use good communication, documentation, keep your ethical principles in the back of your mind. And hopefully we'll find that maze a bit easier to get through.
So thank you, and thank you for all your participation. Can I just draw your attention that if you've logged on with the name of your phone or with something that doesn't tell your actual name, then it's difficult, it's impossible to register your attendance. So thank you to the our fantastic administrators who are looking after us. They've mentioned some specific names. If you're one of those names, please tell us who you are, like if you're Vivo 1906, so that we can register that you attended today. And also, I think I'm going to hand back now to Smiti. Unfortunately, from Pallium India, her call was dropped, but we just have, we're just winding up our session now. We're looking forward to seeing you the rest of this week. And I hand back to Pallium India just to close our session and to give our feedback poll. Thank you.
Okay, thank you, Moira ma'am, and thank you, Jenifer ma'am. Actually, today we have some technical issues. We don't have any live feedback pod, but we will share the Google form to, now I'm sharing the Google form, and the same form I will share on the WhatsApp group also. Please fill it now. I think the form is visible now in chat box.
Yeah, so they put the form on chat box. I love, you've got, somebody said a comment, you didn't even realize we got to the end of the session. Thank you for such an encouragement to Jenifer and I. We've loved working with you today, and we're really looking forward to also the rest of this week together.
Okay, ma'am, thank you. We are signing out, and tomorrow we have sessions on symptom control on the same time. Thank you all.